Okay, good afternoon, dear vets. And as usual, I must thank Dr. Sharma and Mrs. Kanika Sharma for having given me this opportunity to meet you all guys through a web seminar. They've been doing great service to the veterinary society by way of doing this sort of continuing education programs. And it gives me an immense pleasure to see you all guys through this media. We are having finished esophageal disease and stomach diseases. We are now going on to a small intestinal disease and large intestinal disease today. And I want to emphasize mostly on what practically we have to see. And most of the times there might be some tests which we may not be familiar, or in fact even leading institutions may not be doing in our country. But nevertheless, we know the shortcomings and we know how to bypass that and get the best diagnosis out of the present system. So with that, I'll go into the subject, approach to small intestinal diseases. Small intestinal diseases are very common in dogs and cats on a day-to-day basis. Almost forms about 60 to 70% caseload of a veterinarian will be seeing cases of vomiting and diarrhea in small animals. And we need to, whenever we think about small intestinal diseases, before going into diagnosis, we must exclude diseases of other systems, which can also cause, small intestinal clinical signs. So we should always have in our mind a differential diagnosis other than small intestinal diseases when we approach them. More specific tests done to arrive at a diagnosis whenever the case requires that. Most of the acute cases may not require, but acute cases presented to us in a very critical care require some diagnosis, and chronic cases definitely requires approach to diagnosing what exactly is the problem. And of course, we always have treatment trials. Most of the times when you don't have in remote areas, when you don't have all the tests to perform. So, but the disease based on your knowledge, then you can go in for treatment trials, and response to the treatment trials is a diagnosis well made. Okay, now we'll go in for pathophysiology of small intestinal disease. The small intestines relies on other organs like liver, pancreas, and endocrine, because liver's enzyme and pancreatic enzymes and endocrinal controls the small intestinal system to a very large extent. So it relies on other organs. And there can be a primary intestinal problem or a secondary intestinal problem. Most often we see infectious disease when we acquire small intestinal problems. And very many times we also see a lot of inflammatory diseases like IBD and things like that. And different types of diarrhea we always see. Osmotic diarrhea, where there is some non-digestible carbohydrate in the intestine, which draws fluid, and osmotic diarrhea. Secretory diarrhea is, the cells inside the intestinal cells start secreting based on response to endotoxins, and you have secretory diarrhea. Permeability, whenever there is inflammation, there can be problems of permeability of the mucosa, and then of course you have motility disorders. When it comes to motility, we have peristaltic motility, segmental contraction, and you have giant migrating contractions. You should definitely go back to your basics and find out what is peristaltic motility, what is segmental contraction, what is giant migrating contractions, in order to understand various pathophysiology going on in the system. So diagnosis, as usual, history is very, very important. And of course, a thorough physical examination. Most of the times, in a cat, you do see a thorough examination of the oral cavity. You can find a string at the base of the tongue, which is linear foreign body. One end will be in the tongue and the base of the tongue, and the other end will be in the intestines, and they'll be plicating the entire digestive system and thereby causing severe vomition, diarrhea. So the thorough physical examination is a must. Of course, you have examining for organomegalies, thickening of the intestines, prostatomegaly. All these things can be found out by physical examination alone. And initial diagnostic tests, most often when you have a simple case of diarrhea, it is enough if you have PCV, total protein, and then if you have glucose, that should be enough for the initial diagnostic test. But of course, if you want a detailed investigation, you should go in for CBC, biochemistry, and you have specialized investigations, which we will talk about later. So as when you come to history, the age is very important. Young dogs are always affected with foreign bodies, infections, and things like that. And old dogs, usually inflammatory disease and tumors are afflicting the older dogs. So that you should always keep in mind. Breed associated problems always you should have in mind. Like for example, German Shepherds are highly prone for exocrine pancreatic insufficiency. They are highly prone for antibiotic responsive diarrhea, and then terriers are highly prone for IBDs. Boxers are highly prone for IBDs. So you should always have breed-related problems. You should have a back of your mind. Sex, of course, you should know that females are most overrepresented in Addison's disease, and you have pyometra in them causing septicemia and enteritis. So sex, again, you will have to be very careful. And next step, most important step, is to differentiate small bowel diarrhea and large bowel diarrhea. Whenever you have the client says my animal is passing loose stools, then you should ask a number of questions. What is the frequency? What is the quantity? What is the color? Is the presence of mucus? Is the presence of blood? All the tenesmus is there or not? All these things will help you to narrow down to small bowel or large bowel easily. And environmental history, free-ranging pets are prone for toxins because of they are got access to plants, other toxins like organophosphorus, lead. All those problems are there in environmental. You get it in environmental history. And dietary history is again very, very important. What type of diet they're giving? Is it giving a balanced diet or unbalanced diet? Where they're giving any change in diet recently before the episode of diarrhea. All these things will narrow down your diagnosis. And of course, weight loss history is again very, very important. Weight loss, usually happens in chronic diseases, chronic diarrheas, malabsorptions, all these diseases. You have weight loss, which is very, very important. So what are the clinical signs of a small intestinal disease? Usually they have abdominal discomfort. Of course, they are all non-specific. And you have anorexia, ascites. Ascites, again, whenever you see ascites in a pet, we always think about liver. But most important thing we'll have to remember when you're seeing, you will have to think about oncotic pressure, because given by the protein. So when there's going to be pan-hypoproteinemia, then you'll have ascites. This is because of malabsorption. Borborygmus. So borborygmus, increased sounds heard in the small intestinal tract with your either without stethoscope or with stethoscope. Increased borborygmus, again a clinical sign attributable to small intestinal disease. Dehydration, whenever it has severe vomition and diarrhea, you tend to have dehydration, diarrhea, flatters, melena, again very, very important. Whenever you have melena, we should find out whether it is intestinal cause or whether it is extra-intestinal cause. Supposing you have a pet which has got melena and which has also got blood in the urine, then you should think about bleeding disorder, okay, primary hemostatic disorder. Then edema, whenever you have pan-hypoproteinemia, dependent part edema will be there. So vomiting and weight loss. These are the normal clinical signs associated with small intestinal disease. So as I told you, physical examination is very important. Oral cavity examination is never to be spent, especially in linear foreign bodies. Palpation of the abdomen for pain, palpation of the abdomen for foreign bodies, palpation of the abdomen for interoception, palpation for finding out intestinal thickening. So in a cat, is very pathognomonic finding in IBD. Thickened loops of intestine is very, very important. And rectal examination to rule out all rectal diseases like stricture, then foreign bodies, then impaction, fecal impaction. Then of course you'll have to rule out prostatomegaly, which causes dystachia, okay, difficulty in passing motion. So all these things you'll have to unforgetfully do in a case of a small intestinal disease. So how do you approach diarrhea? You have diarrhea, whether it is acute or chronic. Less than 3 weeks is usually is acute. More than 3 weeks is chronic. And mostly it's non-fatal, self-limiting acute diseases, and the symptomatic approach is enough. Sometimes they are, presented in a potentially ill-threatening state. Like for example, hemorrhagic gastroenteritis because of Clostridium. They are presented in a severe shock. And chronic cases associated with polysystemic signs, then small bowel disease and large bowel disease, which are chronic in nature, they all require diagnostic workup, and later on specific treatment should be given. This is how you should approach a case of diarrhea. So I told you about acute diarrhea and chronic diarrhea. Recent onset, less than 3 weeks. Minimal workup required, usually non-fatal. Sometimes fatal systemic signs are shown, and treatment is usually symptomatic. And persisting for more than 3 weeks is chronic. Determine the cause. Large bowel, small bowel are differentiate, and then give prospective treatment. Acute diarrhea. So history is very important, like feeding history, indiscriminate eating habits, all these things are all very important to diagnose and treat acute diarrhea. Physical examination, fever, pain, dehydration, oral cavity, abdominal palpation, auscultation can be done, to diagnose the exact cause. And the core diagnostics which are important in acute diarrhea is fecal flotation, because most of the times we get helminthic infestations which are causing acute diarrheas. Then you can do fecal direct smears for giardiasis and strongyloidosis. Then you can do fecal cytology to find out if you've got excess bacterial population or leukocytes, bacterial overgrowth, fungal or protozoal infection by doing a fecal cytology. So what are the etiology of acute diarrheas? Usually dietary induced, and sometimes you have from history drugs, non-steroidal anti-inflammatories, lactulose being given in a very high dose by somebody. Then sometimes antibiotics can cause severe diarrhea. Toxins, specifically organophosphates, heavy metals, and plants can cause severe diarrhea. Then extraintestinal causes or acute renal failure, pancreatitis, hepatic diseases, and Addison's disease, where there's hypoadenocortisone. And parasitic causes, ascaris and hookworms, whipworms, strongyloids, and tapeworms can cause acute diarrheas. Protozoa, giardia, coccidia, toxoplasmosis in cats, cryptosporidium, and of course viral. We know about corona in cats, parvo in dogs, feline leukemic virus, feline infectious peritonitis, feline parvo. They're all very common viral etiologies for causing acute diarrheas. Of course, bacteria seldom causes, but nevertheless, we should know about E. coli, Salmonella, Clostridium, and Campylobacter. We should think about bacteria because our pets sometimes starts scavenging into areas where they lick crow droppings or whatever dropped by other birds, so they can potentially spread E. coli, Salmonella, and Clostridium. So therefore, such a history is there. We should think about bacteriological diseases. So further diagnostics requires abdominal radiographs, simple abdominal radiograph, thoracic radiographs to rule out metastatic diseases. Of course, thoracic radiographs tell us something about esophageal disease, which can show intestinal signs. And abdominal ultrasound is an excellent mode of diagnostic when to find out about intestinal disease, minimally invasive or not all invasive. Then abdominal contrast studies will throw much more ideas on foreign bodies, interceptions, all those diseases. Contrast studies will throw a lot of diagnostic openings. Of course, endoscopy is an excellent diagnostic mode, but of course, the availability of endoscope might be very less with most of the practitioners. Endoscopy is definitely important. One, to see intraluminal disease. Another, to find out and take biopsy samples for histopathological diagnosis. So whenever you find cases which are frustrating and chronic, you need to refer your cases to centers where they have endoscopy. So serology, we already saw all those diseases, viral diseases. We should do serology like feline leukemic virus, feline infectious peritonitis, feline parvoviral, parvoviral in dogs. And you should know that dogs parvoviral disease can also minimally cause problems in cats. So all these things can be found serological diagnosis. Now we have bedside diagnostic technology for all these diseases available throughout the country. Then sedimentation of urine can throw a lot of light on hepatic diseases. Then, of course, culture. You can see occult blood, the fecal matter to find out about melena, which is not generally seen otherwise. ELISA, enterotoxin assay. When you think about severe bacteriological trend, you need to find out whether they've got enterotoxin, so that you can have a pinpoint diagnosis. It's available in human facilities, so you can always use to find out whether animals suffering from, enterotoxin related GI disease. Chronic diarrhea, clinical signs, hematology, then serum biochemistry, urine analysis, fecal examination. Thyroid testing is very important. I already told you we've got a lot of tests, but thyroid total T4 is good enough for finding out whether the animal is having thyroid. Apart from other signs like having very low heart rate, having cold to touch, and then you have bilateral alopecias, typical of thyroid. All these things will be there along with your low T4. So the ACTH stimulation test is again very important to diagnose hypoadrenocorticism. So again, we know about ELISA, same thing like acute diarrhea. For all viral disease, we require to do ELISA. Specific testing for small intestinal diseases is trypsin-like immunoreactivity to diagnose exocrine pancreatic insufficiency. Folate and cobalamin assay is usually done to diagnose malabsorption, and SIBO, small intestinal bacterial overgrowth, for which this examination of folate and cobalamin assay is there. It's also useful in finding out malabsorption. Diagnostic imaging, again, is very important for small intestinal disease, which is chronic in nature. Ultrasonography, I've already told about ultrasonography. Of course, treatment trial, wherever you don't have endoscopy, wherever you don't have diagnostic imaging facilities like ultrasonography, then treatment trial based on your clinical acumen that will give you rich dividends. Then what are the pathological findings in a chronic diarrhea case? I already told you more than 3 weeks of cases are called chronic. And what are the pathological findings you find? Usually you find anemia, okay, because there will be blood loss, there will be production will be less in immunomodulating diseases, so you'll have anemia. If you have microcytic anemia, then you have shunts and hyperthyroid to be ruled out, especially hyperthyroid in case of cats, shunts in case of dogs. Of course, shunts are also seen in cats. So you should find out if the clinical signs make you include shunts and hyperthyroid in the differential diagnosis when you have microcytic anemia. Macrocytosis you find in feline leukemic virus. Eosinophilia, whenever you get excess eosinophils, then you should think about endoparasitism, of course hypersensitivity, then Addisonian disease. All these things we'll have to think about. Your differential diagnosis should narrow down to these three when you have severe. So whenever you think about eosinophilia or yeah, neutrophilia or neutropenia, you should have absolute eosinophilia or absolute neutrophilia rather than that count alone. Okay, so that is very important again. Neutrophilia usually suggests a severe inflammatory disease. Leukopenia, viral diseases. Lymphopenia, immunodeficiency like IBD, you got lymphopenia. Then if you have atypical lymphocytes in your blood smear, then you should think about lymphoma. When you think about lymphoma, you also have other lymph glands, enlargement. Ultrasound will show you, abdominal lymph nodes enlarged, so you can narrow down on your diagnosis. So causes of melena, I told you about melena. Either you see sometimes frank melena, which is dark in color, or sometimes you may have occult blood. Nevertheless, presence of blood in the fecal matter is melena. Okay, usually you should rule out ingestion of blood, whether the oral from the oral cavity or epistaxis or pharyngeal. All these things you have to rule out. The ingestion of blood, and that will digest and cause as melena. Nothing to do with the small intestinal disease. Then gastrointestinal erosion and ulceration, you have different diseases like uremia, hepatopathies, gastritis, encephalopathies, ulcerations, neoplasia, paraneoplasias, AV fistulas. Usually it's a prehepatic problem, and aneurysms, hypotenocardism, thrombosis, foreign bodies. These are all causing gastrointestinal erosion and ulceration. So when you have melena or if you have occult blood, you should have all these diseases in your differential diagnosis. As you go further diagnosing and further doing, you can eliminate many of them. And hemostatic disorder, I told you, whenever you have bleeding in the GI tract, you should rule out primary hemostatic disorders and secondary hemostatic disorder. Primary hemostatic disorder is only purely do with your thrombocytes. Okay, it's nothing to do with your other factors. So usually vets know whenever you have bleeding, you always go in for injectables like ethamsulate, all those things, vitamin K and things like that. They are all not required for a primary hemostatic disorder. They are all required for factor losses. For primary hemostatic disorder, you only think about thrombocytes. So in serum biochemistry will give you a lot of ideas on kidney function test for renal disease. And total protein albumin will give you lots of ideas about protein losing nephropathy because of renal, protein losing enteropathy because of malabsorption or protein losing enteropathies. Then you think about liver diseases, all these things. The total protein and albumin will give you a lot of lead into diagnosis of these diseases. Liver function test, SGPT, SGOT, and your total bilirubin, and of course bile acids. They are all very important to diagnose hepatic disease, which cause small intestinal diseases. Electrolytes are very, very important. Potassium and sodium are very important. There will be hyperkalemia in case of hypoaldosteronism, like Addison's disease. Of course, potassium and sodium are definitely required to treat fluid disorders, fluid therapies. So electrolytes, estimation of electrolytes is very, very important. ACDS stimulation test to rule out hypotenocardism. Cholesterol can give you inputs into malabsorption. We have several tests for malabsorption, but cholesterol basic serum biochemistry can give you some idea about malabsorption. Of course, TLI, trypsin-like immunoreactivity, to find out exocrine pancreatic insufficiency. You need to go on for exocrine pancreatic insufficiency if the pet shows, clinical signs of exocrine pancreatic insufficiency, like passing, malodorous, huge quantity of, fecal matter, which is malodorous and sticky. Then you'll have to think about TLI. So not that all the tests you should do together. So your choice of tests should make you take one by one your differential diagnosis. Urine analysis is going to give you lots of insights because it's cheaply available and easily done. Specific gravity will tell you about hydration for you to go about fluid therapy. Can tell you about renal disease. Okay, it's going to be dilute urine, not able to concentrate, then it can be a renal disease. Protein in the urine, when you are narrowed down to protein losing nephropathy and protein losing enteropathy. Hematuria with abdominal bleed, think about hemostatic disorder. Sediments in the urine, like biurate crystals, bilirubin crystals, then you have hepatic dysfunction. Fecal analysis is definitely very, very important. So fecal flotation test or fecal smear or fecal examination, whatever you do, and you need to know how specific tests you should do each one. Whether you should do a smear or you do a only centrifuge and see, or whether you should do a flotation. So just go through your notes which you did long time back and accordingly do a fecal analysis, diagnose giardiasis, coccidiosis, Clostridium spores and toxins and helminthiasis like roundworm, tapeworm, hookworm, all those diagnoses can be made easier. Huckle blood, of course, all these things you can do in your fecal examination. Diagnostic imaging is, I told you, is so important to a clinician, and of course, ultrasound. You can diagnose mass in the intestines, foreign bodies, obstructions, peritonitis because you have free gas and you have loss of cellularity in the intestines, intussusception, intestinal inflammation. So when you do ultrasound, usually you'll be able to see on a transverse section, you'll be able to see the 5 layers of the intestine, okay, mucosa and things like that. Those things will be lacking, when you do an ultrasound on intestinal inflammation. Prostatomegaly. So it gives you a lot of your differential diagnosis can be narrowed down by doing a simple radiography and ultrasound. If required, if it is not very clear, you can go in for contrast radiography. And of course, when you have suspect tumors, then you can always go in for thoracic radiography to see metastatic mass. Serum folate and cobalamin. Cobalamin is absorbed in the distal small intestines. It is consumed by the bacteria in the small intestines. Folate is absorbed in the proximal small intestines, and folate is produced in small intestines. With this basis, if you do a test, then you know if it is going to be having increased serum folate, there is a bacterial overgrowth, exocrine pancreatic insufficiency, because pancreatic enzyme is bactericidal. They will completely destroy the bacteria. So if it is lacking that, then you will have more bacteria, and so exocrine pancreatic insufficiency, you will have increased serum folate. Of course, if you have vitamin supplementation, there also you will have more. Suppose you are giving B complex, you might have more folate. Increased serum cobalamin, mostly to do with vitamin supplementation, and decreased serum folate, severe mucosal disease or of proximal bowel, and of course sometimes phenytoin, sulfasalazine should treat for IBDs, or sulfonamides to treat coccidiosis. All these things can lead to decreased serum folate. Decreased serum cobalamin, severe mucosal disease of distal bowel, and bacterial overgrowth, exocrine pancreatic insufficiency, absorption defects in certain breeds. All these diseases can be, all said and done, serum folate and cobalamin, the sensitivity and specificity for this test is not very high, hardly about 70 to 75%. So many of the even higher end institutes usually do not do this serum folate and cobalamin. If you have facilities in human labs, you can definitely do the serum folate and cobalamin, especially to diagnose malabsorption and small intestinal bacterial overgrowth. For other things, you have better, test to, like for exocrine pancreatic insufficiency, all those things you have different modalities. But for malabsorption, this is an excellent test which you can get from human side. So the major treatment for small intestinal diseases, because I'm going to talk independently, but still the overall approach will be fluid therapy is a mainstay because there's going to be severe dehydration, electrolyte imbalances like hypokalemia is going to be there. So you require very good fluid therapy, dietary modification where you give highly digestible, protein, and carbohydrate should be lessened, especially in cats. No carbohydrates. Dogs easily digestible carbohydrate can be given, or you can give a novel protein. Then, of course, adsorbents and protectants, which absorb the toxins and protect the mucosa. All those things can be used for treating. Motility modifiers like metoclopramide or cisapride are excellent for treating diarrheas. Antibacterials, again, this is a very great subject. Normally, antibacterials are not required for treating small intestinal disease. You should have evidence because we are responsible for developing methicillin-resistant organisms, which affects human population to a very large extent. So indiscriminate use of antibiotics should definitely be avoided. So antibiotics are definitely required whenever there's going to be a mucosal defect, when there's going to be shock, sepsis, when there is neutropenia. All these evidences are there that is a bacterial problem, then you should use antibacterials. Okay? And of course, you have got your IBDs, inflammatory bowel disease. We need to use antibacterials. So such of those times alone, use antibacterials. We'll talk about what antibacterial is to use in a small intestinal diseases. Pre and probiotics. Prebiotics are substances which help in the normal flora, which to maintain normal flora. And these prebiotics, are oligosaccharides, which are good for the maintenance of normal microflora. Probiotics, you all know very well, they help in modulating other bad bacteria. They help in phagocytizing abnormal bacteria. So pre and probiotics can always be included in your treatment plan of all SI diseases. It's much, much better than giving antibiotics. Immunosuppressive drugs. There are a lot of immunosuppressive drugs to be used in case of inflammatory disease. IBDs. So you got simple prednisolone, you got budesonides, you got methotrexate. All these drugs we'll again see one by one. Okay, cyclosporins. So you have a lot of drugs which we can see. Chlorambucil. All these drugs are useful in treating inflammatory disease of the digestive system. So dietary modification, acute diarrhea, usually intestinal rest to 24 to 48 hours. This is being questioned, but nevertheless, whenever you give rest, when the animal is presented to you for acute diarrhea, so you introduce highly digestible carbohydrate and protein, and the protein should be a single source. So like for example, rice and chicken, boiled rice and chicken are excellent for small animals, especially dogs, because this diet does not evoke acid production. Because if the acid is produced, already inflamed small intestines and stomach mucosa, this acid production will further aggravate the inflammation. So the chicken and rice is an excellent choice for giving after acute diarrhea. So you give in the 2 to 3 days, you give this boiled rice and chicken, and slowly another 3 to 4 days, add the regular food you give, and go back to normal food after about a week. And cats, they don't tolerate carbohydrates. So single source of protein like chicken is excellent for acute diarrheas. Easily digestible diet. Then diet low in fat and fiber, because fat is again another one which causes a lot of fatty acids, which can cause more inflammation. And fiber is very important for the colonic health. Fiber is important. Then feeding through diarrhea. This is again a latest concept, especially in chronic. You'll have to go in for feeding through diarrhea. They say we should feed in pediatrics. The child which has diarrhea, they say that you should feed through the diarrhea because the enterocytes requires energy to rebuild. So that is required. Glutamine. This is excellent. It's an amino acid which are going to fuel the enterocytes for remodifying the intestinal flora. So glutamine can be added to the diet. So diet in chronic diarrheas, highly digestible diet, similar, almost similar. Restricted fat. It should be palatable with micronutrients because its absorptive function is lost. Therefore, you should use all fat-soluble vitamins when you're giving diet for a chronic diarrhea. As I told you, single source protein is important. 3-omega fatty acid addition is excellent because they are anti-inflammatory. Of course, novel diet and hydrolyzed food. Novel diet, as I told you, carbohydrate and protein which the pet has not taken, usually rice or potato as carbohydrate, and chicken or rabbit or venison or the diet which is not taken. In dogs you can add fish. In cats they are not good, so you can choose a novel diet. And of course hydrolyzed food is again, see, because novel diet, you might prescribe a novel diet, but they may not be owner compliance. So hydrolyzed food is made into smaller molecule size which the antigen doesn't recognize, so that you don't get adverse reactions. So hydrolyzed food, all these things can be given in chronic diarrheas. Protectants and absorbents. So bismuth subsalicylate is an excellent Bismol. It comes under trade name Bismol. It's an excellent drug. I don't know. Generally, Bismol is available abroad for all stomach aches. Whenever you go abroad to US or UK, it's very common. Not so commonly used by Indians. I don't know why. So they probably without that they can manage. So the dose is around 1 ml per kg body weight TID, and you should know that bismuth, this one is salicylate. Is not eliminated in cats to a very large extent, so you should be very careful, and should not be given more than 5 days in dogs, and to a lesser extent in cats. Kaolin pectin activated charcoal. Activated charcoal, I don't know how many vets are using. It's an excellent drug for as a protectant and absorbent. It absorbs all toxins. It is also excellent for poisoning in case of stomach. It's an excellent drug. Kaolin and pectin, time-tested drugs, kaolin and pectin. They're also protectants and absorbents. Motility and secretion modifiers. Anticholinergics, of course, like atropine, they might cause ileus, but nevertheless, severe diarrhea, you can always go in for atropines. Opioid analgesics reduces intestinal secretions. Diphenoxylate or loperamide, they can be definitely given in severe diarrhea where is uncontrollable diarrhea is there. So you can go in for diphenoxylate and loperamide, which is contraindicated in infections because they tend to bind the toxins and not eliminate them. So you'll have to be careful in using diphenoxylate and loperamide. Antimicrobials, as I told you, only if clear indication is present. You should have sepsis, you should have shock, severe shock, because in both sepsis and shock, there will be translocation of bacteria, there can mucosal turnover is there, and therefore there can be seeding of all bacteria, and they can go in for septicemia. Therefore, you will have to use antimicrobials. Increased permeability, which is seen in hematochezia or melena, then evidence of immunosuppression, neutropenia, as an adjunct therapy in inflammatory bowel disease. And what are the best drugs, antimicrobials? Usually we call them as 4-quadrant. Penicillin, you have to take care of gram-positive, gram-negative, anaerobic, aerobic. All these 4 organisms should be taken care of. Usually potentiated amoxicillin, metronidazole, and fluoroquinolones and cephalosporins. And in case where there is no problem with hydration, then you can go for gentamicin. So these drugs can be chosen And remember the 4-quadrant approach: gram positive, gram negative, anaerobic, and aerobic should be always tackled when you are giving antimicrobial therapy for small intestinal disease. So I already talked about probiotics and prebiotics. Prefer to indiscriminate antibiotics, antagonizes pathogenic bacteria, modulates phagocytic action, modifies immune response. Prebiotics are substrate for beneficial bacteria, non-digestible carbohydrate like inulin, fructooligosaccharides are examples of prebiotics. Anti-inflammatory immunosuppressive drugs indicated in IBD, glucocorticoids, so we'll talk about them later. Budesonides, whenever the patient is unable to tolerate glucocorticoids, has excess polyuria, polydipsia, and things like that, then you can go in for budesonide. You can go for azathioprine. You can reduce the dose of glucocorticoids and add azathioprine. Cats, you can add chlorambucil because azathioprine is contraindicated in cats. Methotrexate, cyclosporin, cyclophosphamide. These are all certain immunosuppressive drugs used in treating inflammatory bowel disease. So let us see what are the problems you see in your day-to-day affair, in your practice. So one by one we'll see. So we will deal with hemorrhagic gastroenteritis. We'll see step by step parvovirus gastroenteritis, because many vets, I'm in multiple groups, so they always keep discussing about the protocol for parvoviral enteritis, because they lose pets. Then feline parvoviral enteritis, endoparasitic infection, coccidiosis, giardiosis, food intolerance or food hypersensitivity, small intestinal bacterial overgrowth, antibiotic responsive diarrhea. See, these both are together. SIBO and antibiotic responsive are together. Of course, inflammatory bowel disease and intestinal obstruction like intussusception or foreign bodies. These are normal cases you see in your day-to-day practice. First is hemorrhagic gastroenteritis. You should understand that this is an acute onset. The dog will be fine till yesterday. The pet owner will say till yesterday it was normal. Today morning it has a bout of bloody diarrhea, foul smelling diarrhea. We generally tend to think it is parvovirus gastroenteritis because the owner is giving you a salient feature of foul smell and bloody diarrhea. These two are pathognomonic with paro, so we generally tend to jump to conclusion it's parvovirus gastroenteritis. Otherwise, actually, it's hemorrhagic gastroenteritis. How you differentiate hemorrhagic gastroenteritis from paro? Acute onset. So if you have a sudden onset, see in parvovirus gastroenteritis, you have 1 or 2 days, the animal will be sulking. 3rd day, it will not eat. 4th day, it will have vomition. 5th day, it will have severe hemorrhagic gastroenteritis. But here, hemorrhagic gastroenteritis, you will have sudden onset. Till yesterday it was fine. Today is having hemorrhagic gastroenteritis. Usually you have depression, severe abdominal discomfort, hypovolemia because of massive loss of volume of fluid, and diagnosis mainly by history and PCV of more than 60. So PCV is very important. I told you, whenever cases come, we should be, whether it is a critical care or whether it is a GI disease, we should be able to spin the blood in a centrifuge, microcentrifuge, and find out PCV, total protein, and small diagnoses you can make. So PCV is very important. PCV of more than 60 is highly diagnostic of hemorrhagic gastroenteritis. See, the etiology for hemorrhagic gastroenteritis has not been found, but nevertheless they suspect Clostridium, they suspect other bacterial population which normally doesn't come into bacteria pets environment. So usually we always suspect that it is due to the licking habit of crow shit or pigeon droppings, all those things. This Clostridium gets in the way, or the birds drop in bones. From that they can get Clostridium. So probable cause could be Clostridium or Campylobacter. Okay. So aggressive fluid therapy is most important. So usually you have to go for colloids if you find hyperproteinemia. I told you, whenever minimal database you should have for any critically ill patient is PCV, total proteins you require. And if there's going to be hypoproteinemic, then you'll have to go for colloids. Or if you don't have facilities to do total protein, if you are able to see clinical signs of severe shock. So how do you find shock? If the animal is going to have hyperdynamic CRT, capillary refill time is less than 1 second. Okay, hyperdynamicity. Or if there's going to be hyperdynamic mucous membrane, that is red mucous membrane in the eye, that is again suggestive of shock. Or if there's going to be a severe delay in CRT, both less than 1 second and more than 3 seconds, you should think about shock. When you think about shock, and you should go for colloids because you want intravascular volume. For simple rehydration, crystalloid is enough. In a normal general condition, when you don't have facilities to all these things, you give a mixture of crystalloid, 10 to 20 ml per kg of crystalloids and 5 to 10 ml per kg of colloids. It's enough to treat hypovolemia and other, electrolyte imbalances. And of course, we definitely require to go for antibiotic because there will be going to be a translocation of bacteria and sepsis, and therefore, and there is no severe bleeding, there's a severe mucosal barrier breakdown. So definitely require antibiotic coverage. Remember, I told you about 4-quadrant approach. You require to take care of gram-positive, negative, anaerobic, and aerobic organisms. So you should go in combination of amoxicillin, metronidazole, cephalosporin, or gentamicin if the hydration is good, gentamicin. Okay, the 4-quadrant antibiotic approach. Dietary restriction if vomiting is there. If it's going to be severe vomiting, then don't go in for food. Restrict giving parvos for 24 to 48 hours, then slowly feed. If there's no vomiting, go in for feeding through the diarrhea. You start feeding with with a high quality carbohydrate and protein. That is boiled chicken and rice in case of dogs, and boiled chicken in case of cats. So next is canine parvovirus enteritis. Again, here also you have a very foul-smelling hemorrhagic gastroenteritis, very highly contagious disease. But here it has got a course of illness. The dog will be, if you ask the owner, when was it last normal? He will say it was normal about 4 or 5 days back. From 1 or 2 days it was sulking. 3rd day it is not eating. 4th day it vomited, and today has got hemorrhagic gastroenteritis. So this course will be able to find from the taking a thorough history. So this is very, very important for diagnosing parvovirus gastroenteritis. Okay, usually it multiplies with rapidly dividing cells, like intestinal crypts, bone marrow. So you have bone marrow suppression, myocardium. You have sudden deaths, and lymphoid tissues. All these cells are rapidly dividing, and therefore this virus gets attached to them and rapidly divides along with them. The clinical signs after 5 days of exposure, and the animal is presented with severe vomiting and bloody diarrhea. What is the pathogenesis? There's going to be severe hypovolemia, there's going to be dehydration, there's going to be sepsis, there's going to be shock, there's going to be jaundice, there's going to be disseminated intravascular coagulation. You can see ecchymotic patches in the abdomen in severe cases. So what are the clinical signs? Severe anorexia, depression, dehydration. Sometimes you can have pyrexia, but later on it goes in for hypothermia, vomiting, bloody diarrhea, shock, hypothermia. Later I told you jaundice. These are all the clinical signs of parvovirus gastroenteritis. What are the differential diagnosis? Acute salmonellosis, I told you, hemorrhagic gastroenteritis. Sepsis, any case of sepsis. Maybe it has got a severe pyometra and gone in for sepsis. There also you have bloody diarrhea, which is foul smelling. But there the problem is the pyometra. Foreign body, severe foreign body, which is there for a long time. There again the animal will go in for shock, and you will have severe septicemic shock, and you have sepsis, and you have hemorrhagic gastroenteritis. Of course, about hemorrhagic gastroenteritis I already talked. So what are the chemistry which is going to bother us? Hypokalemia. There's going to be hypokalemia less than 4 milligram per swan. You need to give potassium. Hypoglycemia. This is again very important. So in case of parvovirus gastroenteritis, very, very important that you do potassium and glucose, PCV, and total protein immediately. Pre-renal azotemia, there's going to be severe hydration. There can be increase in BUN and creatinine. But once you give them crystalloids, it will come back to normalcy. Hyperbilirubinemia. So I told you that they'll have jaundice. So you have hyperbilirubinemia. Increased liver enzymes because of inflamed intestines. So now I'm going to give you a complete protocol of what you should do when a case comes. First thing you should do is place an IV catheter. If it's a small puppy or a cat, put a catheter in the bone marrow. Okay, antibiotics, potassium, potentiated amoxicillin, cephalosporins, quinolones in small breeds. First, minimal database, hematocrit, PCV, total proteins, then glucose. These three are immediately we required to see. Fluids, you can see glucose even in your glucometer, but definitely you should correct it to the PCV. If PCV is very less, the severe hemorrhage and the PCV is going to be 20, that means there's going to be no more plasma that will give you a erroneously false higher range of glucose. So you need to be very careful about that. So you can do glucose, whatever estimation you want, you can do glucose. Fluids, crystalloids with potassium chloride, 20 milliequivalents, and 20 ml of 50% glucose as a bolus. You'll have to give glucose. First 1 to 2 hours. Fluid for replacement plus maintenance, you should calculate for 12 hours and give from the total quality, give 1/4 to 1/2 in 1 to 2 hours. You should be able to give. You should have good catheter, big catheter, and then you should give fast fluid therapy. And this time you should warm the fluids alone. Whatever fluids you are giving, that should be warm to body temperature. Then you can add colloids, 5 to 20 ml per kg over 1 to 2 hours if there is shock or hypoalbuminemia is there. After 2 hours, give restore the fluids in 10 hours. You calculate first, you give the 1/3 to 1/2, you give the rest half, you have to give in the next 10 hours. Again, test hematocrit, total serum protein, potassium and glucose. At this point, after 2.5 hours, warm the patient at this point. If you warm the patient before, there will be vasodilatation. So don't do it at that time. After giving fluids, enough fluids, first 2 hours, then warm the patient at this point. Spike the fluids with glucose if required. Again, do a glucose. If it is less than 40 milligram per deciliter, spike the fluid with 50% dextrose again as a bolus. Then you can also go for plasma. Plasma is, preferably if your client has got a dog which had come out of a parvo, then that blood is very good to get plasma. Or if you have a recently vaccinated dog, those dogs' blood can have, that plasma can have a lot of antibodies for parvo. There is immunotherapy. Not only that, plasma acts as an oncotic pressure, so that because there's severe hypoproteinemia, that will also be corrected by giving plasma. If you have an opportunity to give plasma, excellent to give plasma. If you don't have plasma, if the PCV is less than 15%, then you have to go for blood transfusion. Otherwise, definitely is going to have hypoxia and more, sepsis and more catastrophic events following. So you have to give blood transfusion if the PCV is less than 15. After 3 hours, you can go for metoclopramide intravenously or as a CRI, concentrate infusion. Then you should go for buprenorphine for managing pain, because the whole intestines and the gastric mucosa has got inflammation. The puppy will be in severe pain. So buprenorphine should be given TID at the selected dose. Ranitidine again is very, very important because it can, safeguard against ulcers and against esophagitis, which is very important. Okay, in all these cases, we'll have severe esophagitis. Sucralfate, the rate of 1 ml per 3 kg body weight, will coat all these ulcers and mucosa, plus it will safeguard from esophageal inflammation because of backflow of fluids into the esophagus, reflex esophagitis. Okay, so check for BP if you have a BP apparatus. If you don't have BP apparatus, doesn't matter. Check for bladder urine. If there is no bladder urine, that means you have not successfully resuscitated the patient. You require to resuscitate them faster. You can go for other drugs which improve the output, urine output. So it's very important you check the BP or bladder urine and check CRT. If it has come back to normal, 1 to 2 seconds. After 4 to 5 hours, start feeding. Okay. Usually we have been told not to feed parvoviral gastroenteritis cases. Start feeding even if there is vomiting. Start feeding through the vomiting, you start, but given small quantities. 1/3 in 24 hours. Calculate the total requirement, of which 1/3 you give in 24 hours. Every 2 hours, small quantities you give, even if the animal is vomiting. After 12 hours, recheck hydration and continue fluids if it is not hydrated with weight into 10 into percentage of dehydration is the volume of fluids required at this stage. Monitor body weight, blood glucose, TCV, total serum protein, sodium and potassium. Control vomiting, you have to ensure there is no interception. All these cases of parvoviral gastroenteritis, sometimes or the other, can go in for interception because there's going to be a painful, intestinal mucosa. This, there's segmental contraction will be absent, but whereas giant migrating contraction will be continuing, that will make the intestines telescope into each other and they'll go in for interception. Interception can be at any point, gastroesophageal, or it can be ileocecal, or it can be a duodenum. Wherever you want, you can have interception, but ensure there is no interception by doing a thorough, palpation, as also thorough ultrasonography. Ensure there is no interception. Step 1, give metoclopramide concentrate infusion. Step 2, add ondansetron BID to TID. Then step 3, add fluochromazine suppository. Now you have in human, you have this fluochromazine suppository drugs. You can keep it in the rectum. So that avoids vomiting. So deworm with fenbendazole, even if the animal is vomiting. That is again very important, because one of the biggest problem you see in small animal parvoviral gastroenteritis, giardiasis as an after effect of parvoviral gastroenteritis when it is immunocompromised. So deworm with fenbendazole, even if the animal is vomiting. Ivermectin can be definitely given as a helminthiatic drug if the patient is not depleted. If the patient is depleted, please don't give ivermectin. Quinolones 5 to 8 days, especially in small breed puppies. If it is a large breed puppies, potentiated amoxicillin, cephalosporins, metronidazole will be the choice of antibiotic. Okay, now we'll come to feline parvoviral enteritis. So as I told you, parvoviral gastroenteritis, you should think about hydration problem. So then you should think about hypovolemia, you should think about hypokalemia, then you should think about sepsis and septicemia. All these things should be, you should think about, because there's going to be a severe bleeding. So once there is bleeding and sepsis, all the blood vessels will be leaky. To plug these leaking blood vessels, a lot of platelets will be used. So you will have thrombocytopenia. Once there is thrombocytopenia, then there's going to be evidence of more waiting. Or sometimes there can be more problem and it can go in for, clot formation, which will again be another problem. So you have to give anti-clot drugs if you think about all those complications. This is the reason why we have failures in treating parvoviral gastroenteritis. Feline parvoviral enteritis is similar to parvoviral gastroenteritis seen in cats. Young unvaccinated feral cats often affected. Clinical signs are anorexia, depression, vomiting, hemorrhagic diarrhea, and most important physical diagnosis is pain and inflamed intestinal loops, thick inflamed intestinal loops. And when you palpate, the cat resents to it. That's because of pain. This is very typical of feline parvovirus enteritis, prone to sepsis, endotoxemia, and you find that there's going to be neutropenia. Then you need to think about the severeness. In utero infection of feline parvo leads to stillbirth, mummification, fetal death, and abortion. If your queen cat is going to have stillbirth or mummification or fetal death or abortion, you should think about feline parvo. Diagnosis, ELISA. Treatment similar to canine parvovirus. You have to crystalloids, colloids, and 4-quadrant antibiotics, metoclopramide, ondansetron. These are the drugs to use in feline parvoviral gastroenteritis. Mortality, prognosis, mortality is very high in kittens, bad in cases which are hypothermic. So cats are very specific. Whatever the critical care in cats, if the cats has low temperature, less than 98, it will not respond to any of your therapy, whether it is be fluid therapy or whether it is motility modifier. It will not, respond to any treatment. You will have to warm them up to make them respond to your fluid resuscitation technique. So, its prognosis is bad whenever you have an hypothermia and the case disseminated intravascular coagulation. Animal shows ectric jaundiced mucous membrane, then the prognosis is unfavorable.